Hello, everyone. Having said that, my topic for the day is menopause. And I can say with confidence that we Bangaloreans have more awareness than anyone else. Because, my gynec practice is essentially here. But having said that, there are a few things that I think we should interact about in order to spread the knowledge that we, gather here today to everyone else around us. So let's talk about my outline for the day. And I'm just going to sort of, in general terms, define menopause, the types of menopause, maybe a little bit about the diagnosis, because that's important as well, because a woman wouldn't know when she's going through the change, right? Maybe a little bit about staging, the health checks, which are very important through these years, and some common symptoms and how to deal with them. Definitely long-term problems. Lifestyle changes, I'll leave it to Dr. Nitu, and maybe a little bit about other treatments, right? And let's keep it interactive. It's really not a didactic lecture, so please do feel free to raise your hands and ask a question in the middle of the talk. So the spectrum is all the way from, infancy, childhood, menarche, which is the first period, and menstruation from about, say, not even 12 nowadays, 9 to about 50, 55. So that's a whole, what's the range? About 9 years, okay, let's say 10 years to 55 is like 45 years, is that right? So 45 years of periods, and 45 into 12 would be? Right? 550? Yeah. About 500, right? Yeah, 500 periods which a woman has to live through. And then comes menopause. And nowadays we're seeing 80s, 90s quite regularly. So, our lifespans are increasing, geriatric population are increasing. There's so many apps obviously catering to geriatric problems and so many senior living spaces coming up. So I think we have to focus on our geriatric population as well and give them all the care that they need. The reason I put up this slide is to actually tell you about what happens to the estrogen level. And that's the essential difference between somebody who is in premenopause and menopause. So you can see here that this is the estrogen level, the level of estrogen. And through menopause, you can see that it's depleting, right? And then post-menopause, it's still depleting. So as Dr. Nitu rightly said, this is a spectrum and it's a dynamic change that's going through. So it's not that premenopause, perimenopause, menopause, khatam ho gaya. It's still happening and it still will continue to happen. So we should be aware of the long-term issues involved with that as well. So when we say menopause, it is at least 12 months of amenorrhea, which means no periods at all. Unless a woman has gone through the entire year of no periods, even if she's had one, say, a period in about 6 months or 4 months or 9 months, it's still not considered menopause. So we've still got to wait for that whole 12 months to pass around the age that menopause is expected. And if somebody has a bleed after the 12 months have passed, it is called postmenopausal bleeding. And that's something that we need to be, checking, evaluating the woman for. And it's a retrospective diagnosis. That means only after the 12 months can we say, oh yes, I've gone through menopause, right? And it's essentially what's happening is, first of all, the ovarian follicles, we're all born with a bank balance of eggs. Right? What we come out as a baby from our mother's womb, that's the kind of bank balance we carry. And as we grow, so beyond 35, the egg reserve keeps, very, very rapidly depleting. And nowadays I'm seeing 30s and 32s with a very low ovarian reserve. And that's a major concern that we gynecologists are facing in terms of fertility issues as well. But depletion of ovarian follicles go on very rapidly after menopause and around menopause. And also diminution of ovarian hormones, because essentially the ovary is what producing the estrogen, which is keep giving us our skin, our glow, and our bones the health, and the heart its health. And there is unfortunately, no independent biological marker which can say, okay, this lady has gone through menopause, right? So we depend on several history, the kind of history that you give us, some of the hormones and some of the, blood tests, etc., right? And it's the only objective sensitive marker for menopause is irregular cycles. And a woman goes through irregular cycles. They could be frequent every 15, 20 days and then suddenly stopping, or they could be more sort of far apart. So that could happen either. So it need not necessarily be once in 3 months, 6 months and stopping. It could be frequent as well. And there's no need to conduct tests routinely for the diagnosis of menopause, right? And these are some, don't have to go into the medical issues, but one is the follicular stimulating hormone, the other thing is estradiol, which is actually estrogen, and there are a few other parameters seen on the scan as well. Now, the stages of menopause, right? So we have pre-menopause, which is entirely the reproductive period prior to menopause. So it's not like a woman cannot have children during that time. She can still, get pregnant. Perimenopause is those 3 to 5 years before and about 1 year after menopause, right? So it's a long phase of life. And menopause transition is the disturbed menstrual cycle, the endocrinological changes that happen, and then of course menopause as well as postmenopause. The years here, I wouldn't say is pertaining to Indian population, the more of a Caucasian population. I'll come to that in a while. Now, what is the difference between postmenopause and senescence? Senescence is a period after 60 years of age, right? And that's the aging and the geriatric aspects of it and all that. That's different. Whereas postmenopause is a span of time dating from the final menstrual period, regardless of whether menopause was spontaneous or caused by a surgery where the ovaries have been removed, right? Now, coming to premature menopause, this is also a very important health condition where the menopause has happened about 2 standard deviations below the estimated age that for the referenced population. For example, Indians, we say the average age of menopause is anywhere between 46 to 48, Indian women, as compared to UK population who have a menopause around 52, right? So we are about how many years ahead? I mean, about 4 to 6 years before our Caucasian counterparts. And traditionally, it is considered, a premature menopause is considered to be below the age of 40, and, and of course, maybe 38, but below the age of 40 is premature menopause. And the reason we're so concerned about it as gynecologists is that it has a lot of health issues involved because, again, the same problems that a menopausal woman would face, a premenopausal woman would face for a longer time, right? But we do need population-based studies to actually derive at a cutoff. Now, coming to this, that was premature menopause, below 40. Whereas early menopause is when a woman has it between the ages of 40 to the accepted sort of population age, so 40 to 46 or so. And delayed menopause is beyond 54 years. Right? So I'm seeing the entire spectrum. I'm seeing the premenopausal women struggling with fertility, and I'm seeing late menopausal women who come, even at 55, they're still having periods, right? So it's a lot of things, the environment, the stressors, the anxiety, and even what we eat. Everything seems to be playing on our endocrinological system. So as I said, in India, I think it's about 46, that's what we say. Now coming to a little bit about, what exactly happens. And this is one of my favorite slides where, you start getting itchy, bitchy, sweaty, sleepy, bloated, forgetful, and even psycho, right? So the 7 dwarfs of menopause. So the men out here must, I don't know whether you faced it or will be facing it, but that's what's likely to happen, right? And what generally happens is we start talking about symptoms. I mean, the most important symptoms that we see are in the premenopausal, the perimenopausal time itself, When we say vasomotor symptoms, we're talking about your temperature control, right? So you suddenly feel hot even in an air-conditioned room like this, right? You suddenly feel very warm. It lasts for about 60 seconds or lesser or more sometimes. Or sweating for no reason, like those are cold sweats. So those are vasomotor symptoms. Sleep disorders, you could go sleepless for the whole night, or you could initiate sleep, but then when you have some sort of a disturbance in between, you can't really reinitiate, fall back into that sort of deep sleep. Or initiation of sleep itself is a problem, or terrible nightmares, that could be a problem, and frequent loo breaks, maybe skin changes, itchiness or whatever, that dryness, and urinary problems, urgency, frequency, all that could also add on to sleep disturbances. Mood changes, of course. I mean, when I talk to my perimenopausal women, there are like a wide spectrum. It's not just anxiety and sort of feeling worried all the time and sitting, feeling it on the edge all the time, feeling sad, but it's also things like relationship problems, irritability, finding small little mundane things very important in their lives. Right? Suddenly, small little things become the most important issue in their lives, right? So these are all the mood changes that can happen. Then, of course, a little later on, this is the time when the menstrual irregularity is happening. Later on, as years pass with the estrogen deficiency, the vagina, the sexual organs, the vagina atrophies, right? And the vulva atrophies, the skin on the skin around the vagina can have changes like very smooth skin, itchiness, dryness, loss of hair in various parts, dyspareunia, the difficulty with sex, skin atrophy. And then, of course, as the age progresses, it could affect the bones. The bones become weaker. Atherosclerosis, which is problems with, deposits within the arteries, coronary heart disease and cerebrovascular disease and stroke, etc., right? So now just coming to the common symptoms, as I said, let's make it interactive. I'm finding it very boring just going on and on and on. Go on, please. Yeah. So the window of opportunity is, when I put the first slide up, the puberty, menarche, and menopause, right? So we have some windows of opportunity where, as healthcare providers, we can make sure that this woman has optimal health and, lives a optimal sort of life. So the first window of opportunity is infancy, right? Of course, even before that, the first window of opportunity is a pregnant lady. Right? What a pregnant lady does in her pregnancy will affect the baby inside. If it's a girl, obviously, it affects in various ways, even the baby's reproductive health. So that's one thing where we can intervene in terms of many things, to be honest. Then comes the first 100 days of infancy. Then comes adolescence. And adolescence is another huge window of opportunity. And that's probably the last before we can sort of, give them the best health possible. And those 9 to 19 years of age is another window of opportunity. Here, when I talk about window of opportunity, this is a time when I can sort of reduce all these, the circled ones, problems, and that's the time that we have to intervene in order to reduce these problems which occur later on in life. So we'll just come to that. I think, Doctor, you will be mentioning that as well, right? So, go ahead. What are the symptoms that you know of menopause? Yes, please.
How long do the initial symptoms last? The mood changes, sleep disorders, that could last for how long?
They could last for the entire perimenopause and through menopause as well. So it could be 3 to 5 years prior to actual menopause as well, right? So some people are very lucky. Some people aren't that lucky. So it could be, typically on an average, I see it about 2 years prior to the actual menopause. But it could be longer. So all these are the issues: the change in periods, loss of interest in sex, brain fog, forgetfulness, headaches, backaches, loss of hair, especially on the head, and new hair, sort of because of the chin hair and unwanted hair, thinning of the hair in the axilla and the pubis, etc. Please ask. Go ahead, please.
What's the good news?
Yes, lesser waxing sessions, right? Lesser waxing sessions, absolutely. Right. So, okay, that's a little...
I had a question about the previous slide.
Yeah.
Is there anything that we can do about this, or this is just part for the course and we just go and go through this?
We can do about it? Yeah. No, I'm not going to paint a very bad picture, so please don't worry. Let's go ahead and see what we can do about them. Right. The most important thing that I would like to sort of, let's say, the take-home message would be that this is important, right? So a woman who is in her 45 plus sort of age must have certain health checks, and unfortunately our aggregators, like let's say PharmEasy or Practo and those aggregators which do these health check batteries, they do not focus on certain health issues. They just do everything possible. And I see pregnant women coming and doing their lipid profiles and CA125s and all that, which are likely to be high in pregnancy anyway. Right? So when I ask for a certain set of tests for pregnancy, I'm only asking for that. I don't want women to bring the entire, profile, which are done at a lower cost, I think, by these aggregators, right? So similarly, for menopause, there are some tests which are very specific to menopause. We don't want them to do the entire battery. But of course, they are looking at certain specific problems head to toe. So an examination is extremely important. So please don't ignore it, because it's an important aspect that we can, get a lot of information from. So an examination, of course, first of all, I would ask your history as to how your periods have been in the past, how many children you've had, whether you're married or not, whether you've had sex or not, whether you've had any contraceptives in the past. Did you have any pregnancy failures? In your pregnancy, did you have any problems? And that's a very important question, because a pregnancy itself is a window into your health in terms of long-term problems. So a pregnant woman has had gestational diabetes, for example, or high blood pressure issues, or mental health problems, is more likely to be having it later on in life. So what was it like in your pregnancy? Is an important question for me to ask. Similarly, how have your periods been in the last few years? Have you had heavy periods? Have you had a fibroid or endometriosis? Have you had fertility issues? Have you had PCOS where you haven't ovulated very often? These are all factors that I need to know, right? And of course, your health, other health issues, like thyroid, pre-existing thyroid, diabetes, hypertension, cholesterol, vitamin D, B12, everything, right? Urine infections, what have your scans been like, etc. Height and weight, of course. Blood pressure and height and weight, and also body mass index, obviously, and the waist circumference. Now, that is another important aspect of, health interventions. What's your waist circumference? So what's the ideal waist circumference? And what's more important, waist circumference or waist-hip ratio? The ratio, right? But what is the ideal waist circumference for Indian women? 28 is a very high benchmark, right? Yeah. Right. Yes, please.
Pre-baby, that will be different. Post-baby.
Absolutely. Pre-food, it'll be different. Post-food, it'll be different. Yeah. Pre-periods, post-periods, absolutely. Right. Yes, so about 85 centimeters is ideal, and keep it lesser than that. And the body mass index, what is it for women? Indian women, sorry. May I have some water, if that's okay? Is that? Yeah. So what is the ideal body mass index for women, Indian women? Nah. It's actually 18 to 22. Ideal body mass index, right? So what is it basically? How do you calculate it? Weight in kgs by height in meters square. You got it? So weight in kgs by height in meters. So if you're 164 centimeters, it's 1.64 square. So that should be 18 to 22. Is it complicated? Weight in kilograms, so you're 65. Yeah, or you can use one of the apps, or yeah, absolutely. It's very easy, just, yeah, absolutely. So you can all calculate it right now and tell me who is within the range of 18 to 22. Weight in kilograms divided by height in meters square. Yeah, you just go to BMI calculator. I can see some very normal BMIs. For example, the lady next to Dr. Nitu, you must be about 18 or 19 or 20, right? Yeah. I can see the lady in the green, pretty lady in green, you must be about 20, yeah? And probably this gentleman is at a normal, these two are in the normal BMI range. I'm not pointing fingers, I'm just telling the good things, right? But yeah, so that's kind of normal. But once you cross 20, in India, right? Once you cross 22, you're already going towards overweight range, right? And once you cross 27 and a half, you're obese already. Because Indians are thin fat Indians. In the sense, we look thin, but we have a lot of visceral fat inside. So a lot of fat envelops our organs, so which is why we are at a higher risk of diabetes and atherosclerosis and hypercholesterolemia and triglyceridemia and everything, right? All our fasting sugars are much higher in general because our insulin resistance is high. It's too complex anyway. Let's go back to the slide. Blood pressure and cardiovascular system, that's something we check. We do a pelvic examination, a breast examination. The clinical breast examination is very, very important. Although this is done annually from the age of, so self-breast examination starts in 20s, right? It has to start in 20s. So every woman who comes into my OPD, I tell them, please examine your breasts in this manner, every, let's say 2 to 3 months. And then comes clinical breast examination in the 30s, where the doctor would do it for you, right? And then comes the, ultrasound scans and mammographies. So in India, I would recommend mammogram after 45. There are health checks which are done to 30-year-olds who do mammograms. That's really not ideal. It's not to be done, right? The mammogram is an X-ray test, again, an X-ray exposure to your body. So then comes the thyroid examination, which checks. So menopausal women are highly likely to start developing thyroid problems. New onset thyroid problems can come up at this stage, right? And then, of course, waist circumference, what is your physical fitness like, assessment of mood and your cognition. Then, of course, an eye check, because again, this is a time when some refractive changes can come up, right? And of course, a dental check, right? So that all this is very comprehensively to be done. Just an image of all that, right? And this is the breast examination. So ideally, it has to be done in an up and down fashion with the pulp of your fingers, just after a period, not before a period, after a period, while you're naked, look at the bathroom mirror, and up and down sort of all along with this area where there's an actual extension of the breast tissue, right? So until there, the entire extent, or it could be radial, like, circumferential examination. It's very important to do this on a regular basis to identify few of these changes. One is a lump, changes in the skin, dimpling, changes in the nipple, or any discharge from the nipple, right? So this is very important to understand, right? Similarly, a pap smear. Now this picture might look a little scary, but it's a very simple 2-minute test. An internal examination where a little cold speculum is put in, and we quickly take a brush and just scrape the cervix. It's not painful at all, and the slide goes to the pathologist. The pathologist looks under the microscope and tells us whether there are any abnormal cells which may lead on to cancer in 5, 10, 15, 20 years. So it's a precancerous cells recognition or screening test, right? It's not to pick up cancer, it's to pick up the cells which can lead to cancer. And it also picks up HPV virus. Now, what is HPV virus? Human papilloma virus, which causes 99.99% of cervical cancers. So nowadays, we combine the two tests, and if both of them are negative, your next pap smear is in 5 years' time. Right? Whereas if you're HPV positive, you might have to do it more frequently. But please do, I implore all of you and your friends and everybody else in the family to get this done. Then, of course, the bone scan.
Sorry,
Yes.
on the pap smear,
yes.
between 40 to 48 or so, every 5 years, is that sufficient?
So US does it every year. UK does it every 3 years. India, we follow UK. We do it every 3 years. But say there are changes, then we have to increase our frequency, or if the HPV is positive, right? But on a general basis, routine basis, it's every 3 years. Then coming to the until the age of 65, yeah, 65.
65, and between 50 and 65 in UK, we do every 5 years.
That's right, yeah. So the first pap smear is done from 25 onwards if someone has been sexually active before that. If there's no sexual activity at all, you don't need to do it then. Right? It's from the onset of sexual activity to 65. Yes, please.
I already have a uterus removed.
You don't need a pap smear. So it depends on whether the uterus was removed with the cervix. Sometimes the cervix is left behind if there has been difficulties in removing it, but most of the times the cervix comes out. But if one has had a hysterectomy done for changes in the cervix, then they'll need even something called Walt smears, right? Yeah, and this is a DEXA scan. All women 5 years beyond the age of menopause, this is DEXA is basically to look at your bone strength or bone, sort of mineral density, right? So all women who, with a particular risk factor who's had, say, let's say steroids or diabetics or who've had family history, fragility fractures, those who just, literally have a small fall and they fracture. That means that they really have weak bones. Or women in menopause transition with other secondary causes for weak bones. And of course, radiological evidence. X-ray kiya hai, X-ray mein, it doesn't look like a strong bone, then you need a DEXA, right? So yeah, how does menopause affect? I think we talked about this. I'll just go to the next one, right? Yeah, now coming to the worries or the long-term issues with menopause, right? So genetics load the gun, lifestyle pulls the trigger. We all know that, right? And all of us come, I'm not saying all of us, it shouldn't be generalizing, but I come with a big baggage of genetic problems, strong family history of diabetes and cholesterol and heart attacks and whatnot, right? So we are already loaded with those kind of genes, right? And our machines are very different from what our, let's say, forefathers have had. They've had very strong machines. And I think they've kept it that way with all the work that they used to do. My machine is not half as good. I know that already, right? So we have to put in that extra effort because we are not doing all those chakki pisna and, kuttodu, vogiyodu, avella yen marta ilvala. We are not doing all that, right? So we have to do more of that. So having said that, these are our top 10 worries of menopause, right? Osteoporosis, that is weak bones, eventually. Cardiovascular disease, urinary incontinence or dryness or prolapse, where the organs come down. Because ultimately we're all two-legged human beings, right? Homo sapiens. We are not four-legged. So ultimately what is happening is our pelvis is taking the entire brunt. And the pelvis has a bowl of muscles in it. So even in pregnancy, this bowl of muscle is what is taking the entire weight of the pregnancy, right? So we do have things like urinary incontinence, thoda khans liya to urine leak hona, sneeze kiya to urine leak hona, and then unless we do our Kegels exercises literally lifelong. Kegels exercises are pelvic floor muscle exercises. So unless we do them lifelong, we cannot keep them strong, right? So urinary incontinence, genital prolapse, cognition issues, Alzheimer's, other types of dementia, depression and anxiety, sleep disturbances, of course, sexual problems, relationship problems, skin and hair issues, and obesity as well. So what happens in menopause is the distribution of fat changes. Not everybody has these issues, please don't worry. It's just that... Sorry? You're waiting for the fun part. Yeah, I think, Nitu, the fun part is to you, all right? You've got to do the fun part.
I have a question. Can you give me a list of what the men go through as well?
Go on, osteoporosis, men go through what? Just put it across. So osteoporosis is equally there in men, yeah, in terms of old age, right? And cardiovascular disease, post-menopause, we, unfortunately, women have a slightly higher edge on them, which is not too great. Urinary incontinence, we are built differently, so men don't have that issue. Genital prolapse doesn't happen in men. Alzheimer's, more common in men. Hey. Depression and anxiety, more common in women. Sleep disturbances, I guess, again, it can be almost equal, I guess, yes? Sorry? They get benign prostate hyperplasia and they have to go to the loo more often. Correct, good point. Sleep disturbances, sexual problems, equally. Skin and hair issues, equally, I guess. And obesity, equally, right? So some of them do have a little bit of a gender predisposition. Again, a little bit bad news, but I have got to give you some of the facts and then we will have to work on it. So accelerated bone loss, 2 to 5% per year in the first 5 to 10 years after menopause. And then it slows down to about 1% per year. But it is basically because the bone is getting resorbed. So the mineral density is going away without any new bone getting deposited, right? And blood pressure, I don't think 2 years. We've got to get blood pressure checked more often than that. And cholesterol every 6 months to a year. Breast cancer, mammogram after 45 years, and then 1 to 2 years, depending on what the initial screening told us. Fine, yeah. And then, of course, colorectal cancer, colonoscopies are done as a screening procedure for high-risk problems. Cervical cancer, I told you about pap smear. Diabetes, of course, your sugar test. Obesity, your BMI. Osteoporosis, of course, your, the DEXA scan, which I talked about. Menopause will make me an emotional wreck. Good. Well done. Positive people around. Some women do not experience any symptoms at all. True, right? Lucky ones, lucky women. How bad your?
Some people have very painful periods, some people have like periods come and go, doesn't really make a
Yeah.
difference.
Yes.
Is that a good indicator?
Not pain really, but the frequency of periods. So painful periods, once the menopause is over, they're all gone. I mean, but the frequency of periods as to how your cycles have been does have a correlation. To what? To the symptoms you're talking about, or the?
Like in my friend circle, some people have a very bad time when they're having periods. Either their mood swings are too high or they are.
Yeah. PM. You mean premenopause? Yeah.
Some people it happens and it doesn't.
Premenstrual syndrome and stuff. Yes.
Does that indicate how good or bad your menopause will be?
No, but irregular periods can have some long-term consequences in terms of health. But in terms of painful period, it doesn't have any relation to how bad your menopause is going to be like. Premenstrual syndrome, those who have had premenstrual syndrome, it's basically because of the high progesterone in the body, right? So, but if they have had the severe type of premenstrual syndrome, which is PMDD or premenstrual dysphoric disorder, where they have had very bad depression, those are more likely to have issues with mental health problems. But not in terms of the usual menopausal symptoms. Forgetfulness is inevitable. Yes? Right. Okay. So, oops, what have I done? What have I done? Yeah. So loss of short-term memory, it can be a consequence of aging in general, but no, that's not so bad. Menopausal women's sex lives are over. No, right, okay. So basically, because you're relieved of all the problems, you might even have a very good sex life, right? And vaginal dryness and local creams and all that can be used. Estrogen also is a type of HRT which can be used. Menopause causes weight gain? Need not, but there is a certain weight gain, and as I said earlier, the fat deposition changes. So it's less on the face and your curves, and more on your tummy. So it just decides to migrate to the wrong places for some reason, right? That's what happens. The menopause is natural, so it's wrong to interfere by taking a HRT. Let it be. Yeah. So yeah, I mean, absolutely huge proportion, and then I do give HRT for certain selected cases. I don't say no, and there are certain indications for that, right? We'll talk about that eventually. HRT, okay, skip. Can I, wait. Yeah, when can contraception be safely stopped? Yeah, so it's important to know that you are still likely to get pregnant until the perimenopausal age, the premenopausal age, right? Once you've had 1 year of no periods, you don't have to worry, right? Also, the symptoms will tell us, and those women who've had very premature menopause may still need HRT or some sort of birth control in order to give them the advantage of estrogen, right? And can I still use emergency contraception? Yes. And can HRT be used for contraception? No, because it's a much smaller dose. And yes, so I would like to finally, say this. I think our mantra for life should be fit at 40, strong at 60s, independent in the 80s, and nimble in the 90s, right? So all of us, let's hope for that. Fit at 40, strong at 60, independent in the 80s, and nimble in the 90s, and let's see what we can do about it. Just some books that I've written, and I've got some copies of 9 months, although it's a completely different topic. It's about pregnancy. But I became an author last year and released 9 months on Mother's Day last year. So, please do have a look and see what you think. It's all on Amazon since then. And I will hand over the stage to Dr. Nitu, who will take it forward. Thank you very much indeed for your patient hearing. Question? Yeah, go ahead.
So this is on the back of my second book, but I want you to focus on the word flourishing. I want people to realize that perimenopause and menopause is, while it's a natural phase in a woman's life, like Aruna said, we are not dying in childbirth, we are not living till 35, 40, that was the average life expectancy of 50. We hope now to live into our hundreds. We are living into our 80s. The idea is that we want to learn how to flourish because we are here on this earth just this time, and we want to learn how we can maximize the time that we have usefully and happily to our satisfaction, and trying to make the best with the cards that we have been dealt with. So that's important for me to mention. I also want to mention that I don't like the word that the Americans use of midlife, that midlife is used for perimenopause and menopause, but we have to remember that there are a lot of people who actually stop their periods much earlier, as early as never ever starting a period at the age of 10 or 11, and that happens in 1 in 20,000. And there are people like me who had premature menopause is a word that we don't like to use very much nowadays. We like to use the word premature ovarian insufficiency and not premature ovarian failure, because we are not failures. Our ovaries have just decided to pack up. And I stopped my periods at the age of 38. And I do feel quite strongly that we want to include everybody, however you may identify, whatever gender you may be, as long as you have female reproductive organs, and also whatever age you may be. And I want men to also be part of this discussion, because you're always going to have somebody in your life that is going to go through this phase. So unless you know about this, and unless the women in this audience advocate for themselves, it's very hard to be heard. Otherwise, you'll end up not really getting the answers that you're looking for. I've had about 40 years of experience. I trained in Pondicherry in JIPMER and then in All India Institute before deciding to go to the UK, hoping to come back in 4 years, and I'm still there 32 years later. Just some menopausal statistics. That's 1.2 billion women will be menopausal by 2030. And the average age of menopause, depending on whether you're from the north of India or the south of India, as nice studies done by Lancet, it can range anywhere between 45 and 47. But the important thing to understand is stopping your periods under the age of 40 or under the age of 45 is 3 to 4 times more common in India. And so we are trying to find the possible causes, and there may be genetic factors as well, but it's important to be aware of that. And we do talk about hot flashes, but fatigue and joint pain seem to be more of a problem for Indian women than hot flashes. And so again, it's important to tailor our treatments and management towards that. And also, a lot of us are still at work. I was 38, I was applying for a consultant job. And many of you at 45, if you're stopping your periods, you're still at work. At 60, you're still at work. So we are not really doing enough service by actually putting important information at the workplace. And 3 in 4 women do experience symptoms. They don't have to be all doom and gloom, and that's why I do want to explain these things. But there are women who will have severe symptoms, and unless there are things in place, it's very hard to be heard and to actually make this very important workforce very productive. And there are also the way you look at things. It might be a fantastic thing for somebody who has had a history of endometriosis or adenomyosis or polycystic ovary syndrome. Stopping their periods might be very liberating. For those who had painful periods, it might be liberating. Also, culturally, you may have a higher standing in society. You might be able to enjoy sex more freely. Lots and lots of things. And I discuss all this in very much detail in my book. Every single aspect that you think of, I have tried to bring into the book so that people get the answers there. I want you to keep this picture in mind. What color do you see? Yeah, so just think of this, because I'm going to come back to it. So Usha is a 48-year-old woman who's noticed that her periods are coming more often. As Aruna said, you can have increased frequency of cycles. You may notice that instead of your 28-day, 30 or 32-day cycle, your periods are coming every 24 or 25 days. They're not particularly heavy, but if they are, it's very important to get it investigated, because you may be having, if they turn newly painful, you may be having a background of adenomyosis, which is a cousin of endometriosis, and painful periods can last into menopause because endometriosis often is underdiagnosed, and that can leave you with scarring and bowel adhesions and things. All those symptoms can track itself into menopause as well. But in this particular person, she's struggling with her weight, and most people start putting on weight in their 30s, and men as well as women, but during menopause it can go up to as much, usually 1 to 2 kilos, but up to 10 kilos, and usually, as Aruna said, they are around the midsection, so you don't like your muffin top very much. She has a sister and aunt with breast cancer. She wishes to avoid HRT, although it's not a contraindication. She can actually have HRT, and I would be very happy to give her HRT, but for now she wants lifestyle advice. And I want you to remember this: it's never too early and it's never too late to learn about menopause and to bring in lifestyle changes. It doesn't matter whether you take HRT, whether you take blood pressure medication, whether you take diabetic medication, you want to bring in lifestyle approaches, because if you do that, you will find that you can either reduce your medication or you can have less side effects and you can actually live a better life. So this is where lifestyle medicine comes in. So when you say lifestyle advice, you do need to provide scientific, evidence-based, backed-up information. Not information because Dr. Bajekal thinks so or Dr. Muralidhar thinks so. No, it's not our opinion. We have to have science and research backing it. Otherwise, that person is not giving you the right advice. So lifestyle medicine involves the use of evidence-based approaches, and the important thing to understand is that it is not Western medicine or lifestyle medicine. It's not one or the other. It can often go hand in hand, it complements it, but the difference is that in Western medicine, I as the doctor am in the driving seat. In lifestyle medicine, you as the person is in the driving seat, because self-care and self-management is key. So knowing the questions to ask your doctor, knowing how to research the right resources, knowing how to bring in the lifestyle approaches, that's what you're going to educate yourself about. Because if you don't, you're going to find yourself left behind and at the hands of people who may not necessarily have your best interests at heart. So there are 6 pillars of lifestyle medicine, and they're applicable to perimenopause and menopause as well. And what are those 6 lifestyle pillars? I'll be going through them in detail. The first one is trying to bring in more plant foods into your diet. The second is regularly moving your body. The third is trying to make sure that you sleep and you have restorative sleep, not when you're scrolling on Instagram, on Reels, and then falling asleep. Finding ways, managing your stress, because all of us have stress in our lives. Finding a way to avoid risky substances, because while it might be cool to have a cigarette or have a glass of alcohol, it becomes regular, and if it features in your life, you're going to hurt your health, especially with your menopausal symptoms. And also having friends and family that actually bring you together. That is the power that is often not spoken about, because loneliness is as bad as smoking 15 cigarettes a day. So let's talk about diets. Unhealthy diets, especially in all Western countries and in India, are now responsible for 1 in 4 deaths. 11 million deaths could be avoided if people ate just some more fruit and some more grains. In fact, 60% of the diet in urban India as well as in the Western world is now consisting of a lot of ultra-processed foods. And so consumers are confused. They are told ghee is good for you. They're told that 80% of the information they read, one day they'll read something in the Times of India, and then next day they'll read something else, and they get confused. So they go back to eating and behaving the way they normally do, because they don't know which is true, which is not. Because an influencer might say something, a doctor might say something, a trusted doctor might tell you that, eating plants is bad for you, or eating grains is bad for you, it'll cause inflammation. So you get confused. So then you go back to eating the samosas and the regular foods that you think, anyway, I'm going to die, it doesn't matter, it's all, menopause is anyway doom and gloom, as well might enjoy that jalebi, So what happens when we eat like this is that we end up with a heavy world. We are now facing 70% of the Indian urban population is either overweight and obese. As Dr. Aruna said, BMI above 23 is considered overweight, above 25 will be obese. And that's different because of the way our fat distribution is. And what happens as a result of that, along with a sedentary lifestyle, we have the maids doing the cleaning, we go in a car to the gym, or we may not even go to the gym, we go in a car to work, we come back and we watch television. So sedentary lifestyle, along with diet, along with the stresses of daily life, along with adding an alcohol on the weekends, and socioeconomic factors, having a partner that's not supportive, all these things end up with having huge negative impact on the way we experience menopause. Type 2 diabetes is increased, hypertension is increased, dementia is increased, and women are particularly at higher risk of Alzheimer's, 2 to 3 times more than men. In fact, it's the biggest killer in the UK now over cancer and heart disease. And so the risk of many cancers, lifestyle-related cancers, so breast cancer, prostate cancer, liver cancer, colon cancer, these are all increased when you're carrying more weight. And you can see you can see this chart over here from the American Institute of Cancer Research. And of course, even during pregnancy, obesity has a lot of, and being overweight has a lot of implications as well. And so remember that blue beautiful sea? Those are the blue zones. We want to live in a blue zone. You want to create your own blue zone in your house and outside. And these are 5 places where people live the longest and the healthiest. And they have drilled it down to many factors, but one of the most important, or 2 most important factors are they live in a community, and so they have a lot of support, but also 80 to 95% of their calories come from whole plant foods, so beans and fruits, and they tend to eat at least 3 times a day amounts of beans. They eat very, very little animal foods, and in fact in Loma Linda, a lot of them are completely animal food. They do not have any animal foods at all, so they're vegan in fact. The 7-day Adventist. So this is me in Japan last month, and I was so taken away with how beautifully they approach food and the way they respect everything. Every single thing seems to have a soul, and proper nutrition does seem to be the key to unlocking the body's potential. But you may not necessarily start with food. You might start with sleep, and then you might start moving your body. So it's a domino effect. It's not that you have to do everything to 100%, but when you start doing things, what happens is that when you start eating better, you tend to sleep better. When you sleep better, you tend to stress less. When you tend to stress less, you tend to want to move your body. You want to make a phone call to your friend and maybe go for a walk instead of going for a coffee. So those are the things that are really important to understand, that it's not just one aspect. You want to try and bring all the aspects, but we do believe from all the science for health, and especially menopausal health, we do believe that diet has a huge role. And you want to focus on foods that are rich in fiber. There is 0 fiber in refined foods, so all the fried foods that we eat a lot of in India, all the animal foods, they have 0, 0, 0 fiber. So you want to really focus on bringing your body nourishing your body, and you're only able to eat a certain amount of food, about 2 to 4 pounds of food in a day. So you want to be bringing food like fruits and vegetables and beans and whole grains and lots of tofu and soya, potatoes, sweet potatoes, lots of beans, herbs and spices, mushrooms, seeds and nuts. This should be the basis of your diet. And very, very occasionally, you should be eating the right-hand side, and you should try to minimize salt, oil, and sugar. All these things are on my website. Please do not worry. Everything, all my information is available free on nitubajekal.com, so you don't have to even buy the book. So why is it so healthy? Because it reduces inflammation. It reduces...
Sorry.
Yes.
Can you interrupt?
Yes, go for it.
What do you mean by the estrobolome?
So the estrobolome is... So the gut microbiome is really important for us. We know that the bacteria in our gut decides how the rest of our body behaves. Are we going to get Alzheimer's? Are we going to get breast cancer? Are we going to experience menopausal symptoms? That are the bacteria that live in our gut. Now, those who eat a lot of whole plant foods will tend to have a different set of gut bacteria that are healthy and promote gut health and promote heart health and brain health. Those who tend to eat a very high amount of ultra-processed foods or animal foods have a different set of bacteria such as Shigella, Salmonella, and things like that. Now, estrobolome is a particular group of bacteria that are specially there that synthesize the estrogen. And I discuss that in a little bit more detail in my book. And so when we have high levels of exogenous estrogen, say from dairy or from body fat, then the estrobolome actually synthesizes it and allows it to be excreted out in your poop rather than going back into your liver and causing havoc in your breasts and your prostate and in your body fat. So estrobolome is type of gut microbiome that will actually help in protecting protecting us from reducing our menopausal symptoms, because there are 34 different symptoms. You can choose and pick. You can have feeling of ants crawling under your skin. You can have ringing in your ears. You can have soreness and things. But again, I just want to say that I don't want us to think that we are batty women who need to be managed by a lot of paternalistic behavior by men outside. So I do want us to actually take that away and shut it down, where you want people to be aware that actually we are a very important part of the workforce, very important part of community, and we should definitely stand up for ourselves, because we do not speak up enough for ourselves. We are always bottom of the list, even below the dog. So remember that. Yeah? So why is eating whole plant food so healthy? Because of a number of factors. It maintains a healthy gut, it reduces our blood sugar, it improves insulin resistance, it helps to maintain healthy weight, it reduces inflammation, which is the driver, the building block of most diseases. And coming to menopause, we know study after studies have shown that when you eat more whole plant foods, so study in China where women had high blood pressure, they found reduced menopausal symptoms. When you go plant-based, vegan, you tend to have much less menopausal symptoms, hot flushes and joint pains and fatigue. When you eat a plant-based diet that is focused on soya, that makes a significant difference in your perimenopause and your menopause with regards to hot flashes. When you eat vegetables and fruit, you reduce menopausal symptoms. In contrast, when you eat laddus and jalebis and samosas and bacon, you tend to worsen your menopausal symptoms. When you eat nuts and seeds and vegetables, you tend to reduce your risk of dying. When you increase saturated fat in dairy and in animal foods, you tend to increase and worsen your menopausal symptoms and have a higher rate of death and osteoporosis. So we come to phytoestrogens in plant nutrition. And it's important to understand that phytoestrogens are very different from the estrogens that you find in dairy or meat or in your physical body, in your body fat. So phytoestrogens are plant estrogens. They have very weak activity and they're very clever. They block the action in certain tissues and they promote the action in certain tissues depending upon how many of the estrogen receptors are filled. And phytoestrogens are not present just in soy. They are the strongest and the best present in soy, but they're also present in blueberries, in chickpeas, in beans, in flaxseed, in linseed. So it's important to try and bring all these foods into your diet so that you improve your plant estrogens for men to reduce prostate cancer and colon cancer and liver cancer, for women also to reduce the risk of breast cancer and improve menopausal symptoms. And this is a quick little slide. It's a busy slide, but I just want you to focus on the left side where you can see that estrogen that is present in our body and as well as in dairy and meat will work on both the alpha and the beta receptor. So it cannot differentiate. While soy works, the isoflavones will work on the beta receptor. So in breast, it will reduce the risk of breast cancer. In bone, it will promote the growth of bone and reduce the risk of osteoporosis. So it's a very, very clever component of soy as well as chickpeas and things. But the highest concentration tends to be soy. So it's really important to bring this food into your diet and trying to bring in at least 2 to 4 portions in a day, depending on how much you work out. And a lovely study by Dr. Neil Barnard which showed 84% reduction by just having half a cup of mature soybeans in a diet and the background of eating more plants was reduced in this group in 12 weeks by 84%. And that, if it was a medication, everybody would be running for it. It's food, so it's not so important because I can't make any money because it's not Dr. Bajekal's supplement. Later is better. Because I'm just conscious of time, so I just want to just note your questions and we're going to have time for questions. So even 1 portion of soy per day in childhood can reduce the risk of breast cancer in men and women. And so the earlier you start it, the better, but it's never too early, never too late to make changes for menopause and for breast cancer. It reduces the risk of colon cancer, lung cancer, prostate cancer. So men who drink dairy have a 25% increased risk of prostate cancer. Men who drink soy milk and eat soy have a 25% reduction in prostate cancer. And we're talking about aggressive prostate cancer. We're not talking about the benign prostate cancer that occurs in people who are 90 and 100. Postmenopausal, so women who have breast cancer, the more soya they bring into their lives, lives will actually have a reduced risk of dying if the cancer comes back. And there are beautiful studies from China showing this, many good randomized controlled trials. Eating soy will also help you with weight loss, have a slimmer waist, is heart healthy, and has bone health protection. And beautiful study done by the Hull professor, Professor Satyapalan, looking at the intake of soy and osteoporosis reduction. And remember that soy is safe. You don't have to worry so much about GM. All foods that we eat are GM produced, but if you want to eat organic, that's fine. I'm not a great fan of spending more money. I don't think it's needed for any fruits and vegetables. You need to wash them properly, make sure. But yes, if you can afford it, of course, eat organic. Choose whole plant foods like edamame, tofu, tempeh, soy milk. If you have a handful of tofu every day and a glass of soy milk, you will get probably about 40 to 55 milligrams of isoflavones that can help you with managing many of your menopausal symptoms, but also giving you all these protections. And I tend to eat about 4 portions because I do quite a lot of strength training, but for people, they can have 2 portions. That is a handful is a portion, so about 80 grams. So, a small block of tofu from Namdharis or wherever you get it. And what about protein? People are so worried. Well, the largest animals that roam this planet are elephant, hippo, giraffe, the rhino. What do they eat? Plants. And you say, but Dr. Bajekal, I don't want to look like an elephant. Well, what do the deer and the antelope and the gazelle eat? They eat plants. And usually the lionesses who do all the hunting will be failing at their job 9.9 times. They get a hunt only from the lame, the young, and the old. So protein is there in every plant food. It's really boring when people ask you, what about protein? But just to tell you, tofu actually has more protein than an egg. So that is important information. If you don't remember anything else, even oranges will have calcium and protein. Everything has protein. But when you want to look at really good plant-based sources, these are your plant-based sources. Try to eat within the circadian rhythm. Try to have a heavier breakfast. Try to eat lunch like a princess, and try to have dinner like a pauper. Try to finish your meal early by 7 o'clock. I know in India they tend to eat much later, but it's really something that you want to do. So you can bring in a small amount of intermittent fasting, and do not exercise ideally on a fasted stomach. Men can do it, but women don't actually do very well. And I discuss all that in detail in the book as well. And try to follow hara hashibu, which basically means don't eat until you're so stuffed that you can't get up. Try to eat about 80%, or even 60%, so you're actually a little bit hungry when you get up from your table. So that way you feel that you know that you're actually allowing your body, because sometimes we eat so quickly, our mind actually doesn't keep in touch with the stomach, and so you think you need much more than you actually do. And sometimes you mistake it for thirst as well, so make sure that you're drinking enough water. So as I said, it's not just about diet. We also want to look at the different aspects, and moving your body regularly makes a very big difference. It improves insulin sensitivity, improves sleep patterns, but it also helps with menopause and menopausal hot flushes, and reduces a lot of risk of many cancers and the risk of cancers coming back. And so we want you to move your body ideally an hour a day. Doesn't matter how you do it, yoga, Pilates, tennis, badminton, dancing, it doesn't matter. But what you also want to do is bring in some strength training. It is not negotiable. You want to bring in strength training as soon as you hear about it. At least twice a week, you can get weights, you can watch YouTube, you can get a personal trainer. Don't buy that sari, go and get that personal trainer. Make sure that you actually invest in strength training, because when you build muscle, you reduce your visceral fat, and that's what is going to keep you more alert, less Alzheimer's, less heart disease, less diabetes. So you really want to do this earlier, as soon as possible, and all the men in the audience as well, because 1 in 3 women will die of a hip fracture. The other 1 in 3 will die of Alzheimer's. So you want to use lifestyle to reduce these risks. Sleep. I'm not going to go too much into how you can improve sleep. It's all on my website. But you really want to be trying to get 7 to 9 hours. This is the lifestyle pillar that I fail miserably every single time. Being an obstetrician for decades, as well as becoming menopausal at 38, I am over the moon if I can do 6 hours. And also I'm always in this rush to do 200 things. But really we know that sleep is, because it's used as a form of torture, right? You can go without food for many, many days. You cannot go without sleep. So it's used as a form of torture. So you know that this is probably the most important pillar. And when you start sorting this out, you start looking at your husband maybe with some love, and he won't irritate you so much. You won't want to kill him, so your stress levels will reduce. You'll want to make healthy choices. So it's really important. We all have stress. We're not talking about acute stress. We're talking about chronic stress. And you identify your stress triggers. What is bothering you? Is it your work? Is it something that is bothering you? Try to identify it. Can you make a change? If you can't make a change, find ways. Find breath work. Find meditation. Find reading a book. Find laughing with a friend. Find something so that you can reduce those stress levels, because they will make your menopausal symptoms, they will make your weight gain, they will make your cortisol levels, they will make your insulin resistance much, much worse. And there are a whole host of finding ways, and you will find something that will suit you. And it might be just going for a run, it might be going for a walk with your friend, it might be watching your favorite television program, but find something that will reduce your stress. And I cannot stress the importance of building positive connections. Try and give back to the community. It is such an important thing that you can do, because we are so lucky, we are so blessed that we are not the people having to, be in war-torn areas or go without food. So really you want to try and have a life purpose in some way, whether it's looking after your grandchildren, whether it's helping an older neighbor or your in-laws or your parents. The next lifestyle pillar is just trying to remember that you want to keep away from fried and ultra-processed foods, because they contain advanced glycation end products, especially foods that are meats, and things will have chicken, and things will have high levels of AGEs, which will damage the ovaries as well as the blood vessels and worsen conditions like polycystic ovaries and menopausal symptoms, and of course increase the risk of cancer. And do not be fooled with alcohol. The safest limit of alcohol that you can drink as a woman or a man is 0. Okay, anything that you do above that, you do it mindfully, because even 3 alcoholic drinks in a week, which by that I mean 3 units. 1 unit is 75 mils. So most glasses that are poured are already 200 mils. Even drinking that 1 large glass will increase your breast cancer risk by 15% and 10% every time more that you add 1 more glass. So do not be fooled, and brain health is really affected. Already we know it's affected in menopause, and when you drink alcohol, it worsens your the brain functioning. So remember that hot flashes can be very common, so you want to try and find ways of bringing those hot flashes down. But HRT is something that I'll discuss quickly in 5 minutes, but you may be able to take it, but you may not be able to take it. And so it's absolutely safe for the vast majority, but for those who can't take it and those who can take it, you still want to bring in all these measures. And lifestyle trumps genetics when it comes to cancer. Okay, so because as we get older, we have higher chance of mutations. So you want to remember that lifestyle is really important. So definitely move your body, definitely stress less, definitely sleep better, and try to bring in these foods. So you can see soya there, green tea there, flax seeds there, turmeric there. Eat your greens, G-bombs, okay, the greens, beans, onions, mushrooms, and berries and seeds. And try to reduce your risk of dementia. This is me with my book club, all holding the book in my book launch. But it's important to find your tribe. It's so, so important to try, and those are my 2 rescue dogs. So remember all the 6 lifestyle pillars that we talked about. Stress reduction, sleep, movement, nutrition, positive social connections, and reducing risky substances. And it's never too early and never too late. And do learn how to examine your breast yourself, because at the end of the day, a doctor is going to see you once a year. They don't know your breast. They're not going to pick up things. Most breast cancer is picked up by the person themselves. So do it after a period if you're still having periods. If you're not having periods, once a month, dedicate time to actually examine your breast. And also go for your screening as and when it's recommended. Not too much, not too infrequently. And be patient with yourself. Talk to yourself like you would talk to somebody who you love the most. We women tend to talk to ourselves very, very harshly. So be patient with yourself. Try to bring in small changes. Don't rush and make all the changes. Try to bring in a large salad, large soup. Eat big dals, big portions of rajma, not the small katoris, so that the more color you bring into your diet, the more you will find that you will actually improve your health. And it's not about what you're giving up. People say, oh my God, you're asking me to give up paneer. No, it's what you're embracing. And that's what you'll find. It's really important because that is what is driving climate crisis, animal agriculture. So there are no healthy people on an unhealthy planet. And that's not the planet you want to leave to our children. And so, do I have 2 minutes to discuss HRT or you don't want? Okay, so this is Damini. She's 48 years of age. She's not had periods for a year. Remember, the average age of menopause is between 45 and 47 in India. It can go, the average age all over the world is 45 to 55. And so she is somebody who's menopausal now. She's struggling with hot flushes and fatigue and low mood and disturbed sleep. She has no real risk factors. She's slightly overweight. She's got some raised blood pressure. She wants HRT. She's not that interested in lifestyle, although you want to talk to her about that quite significantly, because it's whether you take HRT or not, you're going to be doing lifestyle for the rest of your life. HRT, we normally say about 5 years around menopause, so say from your 2 to 3 years before you stop your periods till 4 or 5 years after, but it's somebody's choice, and you can take it. I have 90-year-olds who are on HRT. So I answer all these questions on my website as well as in the book, and so I just want to mention that if you still have a uterus and haven't had a hysterectomy, you need estrogen and progesterone. We start with the lowest dose unless you're somebody with premature ovarian insufficiency or early menopause, or surgical menopause. If I have had to do a hysterectomy and take out the ovaries, I will start at a much higher dose. Otherwise, I start with the lowest dose and go up. I'll assess in 3 months, or the family doctor will assess in 3 months, and then yearly. And we tend to prefer, especially she's got high blood pressure, so you tend to prefer a transdermal route, which means either a patch or a gel or a pump, and you can take oral progesterone or have a Mirena coil if you still need contraception, or if you have conditions like endometriosis or adenomyosis, HRT can cause a lot of irregular bleeding if you're not aware of these background symptoms. So it needs a little bit of skill to know how to make sure, because people often give up HRT because they've read somewhere it's unsafe, that it causes cancer, which it doesn't. So it's important to know that and not to deny your patients when they're struggling, especially for a few years, to improve their quality of life. And it also makes them in a better place to bring in lifestyle changes. And vaginal estrogen is safe. It's for vaginal changes and dryness, and it's not HRT, and you can use it for the rest of your life until you're 110. It helps to reduce cystitis and makes sex more enjoyable as well. Other decisions about when to stop, when to start, all those I discuss both on the website. But I just want to say that the most effective treatment is estrogen and then plant estrogens. And you don't want to take phytoestrogens or soya in the form of tablets. You want to take it in the form of the whole foods. And the chance of getting breast cancer is not increased if you take only estrogen. If you're on estrogen and progesterone, you have 2 extra cases in 1,000 women over 5 years. So really, the risk of breast cancer in modern preparations is negligible. That should not be the one that is driving your decision. The risk of clots is also not what should be driving you. It is quality of life that you have to decide. And I feel strongly, because I was denied HRT when I should have been put on it, despite being a consultant, because I made the mistake of not reaching out to my colleagues because they were men, and I was very ambitious and I wanted to be the top of my profession. But my GP refused, because that time the studies had shown that it could be dangerous because they had misinterpreted the studies. There are some contraindications, like personal history of breast cancer or personal history of clots. But there are several decades, so you want to encourage lifestyle changes. You have to be very careful taking herbal medicines and various supplements, because they are not safe. They have not been actually studied very well, but there are a lot of other things that you can do. Hypnosis, acupuncture, swimming, yoga, all these things can help as well. And so I tend to go to lots of schools and community where I try and educate women to empower themselves. And we have very vibrant websites where we try and engage. I'm also on Instagram and on TikTok, so do give me a follow. And that's Rohini, my daughter, who's a lifestyle medicine professional, who was my co-author. So you can explore more free information on our websites. Thank you.
Hello.
Hi. So I've seen a lot of use of soya in one of in your slides, and because I have hyperthyroid, there is a myth that soya.
It's a myth.
It is.
It's a
yeah.
myth. So the important thing to understand is, yes, soya does compete with thyroid, with thyroxine for the thyroid receptors. So what you want to do is if you are on thyroxine, you want to have soya a couple of hours gap. So ideally thyroxine should be taken on a fasted stomach. Hyper doesn't matter. No. But anyway, whichever way it is, you want to have soya separate from thyroxine, if you're on thyroxine. If you've got hyperthyroidism, then you may have been put on medications such as radioiodine and now are on thyroxine because you're a hypothyroid. But if you're not on any treatment, it shouldn't matter. But generally, anybody who's hypothyroid is on thyroxine, you want to take thyroxine, say, at 5, 6 in the morning. Give us a couple of hours before you have your porridge with soya milk and things like that. I think they're waiting for Mike.
This question is for Dr. Bajekal. You had a slide about estrogen and C-reactive protein. Could you please, the effect of estrogen on C-reactive protein?
So we're talking about exogenous estrogen, not HRT. We're talking about estrogen from our body fat and things. C-reactive protein is an inflammatory marker. So basically, when you eat a lot of inflammatory foods, they can increase your C-reactive protein, your ESR. That's what it basically means. Inflammation is marked out by homocysteine, CRP, and ESR. So we know that when you eat inflammatory foods, and many of the inflammatory foods do contain exogenous estrogen. So you want to be quite mindful about that because people are often not aware of that. Does that answer your question?
And my CRP protein is really high.
Okay.
So I just haven't been able to, wrap my head around that.
Yeah. So if that is the case, it might be that if you should find out what your visceral fat is. So BMI, for example, is not any marker for health for women, especially in menopause. But generally, because if you're a bodybuilder, you'll have a very high BMI, but you're actually mostly muscle. We all carry a lot of visceral fat, and that is where inflammation sits. So that may be one of the first starting points to see actually why. And when you mean high, it depends upon what ratio and which lab you're doing as well. So I'll be interested. You can show me afterwards. Yeah.
I guess the other aspect is which CRP are you talking about?
That's what, so we need to see what.
So you need to, so the generic CRP, which we use only for, treating women,
Yeah.
I mean, people with infections and things like that. There's a high sensitivity CRP,
As
which
well.
is part of some health checks, and people get it done, and it tends to be high in certain phases of life. For example, in pregnancy, it's high, and, that sort of a thing. So you need to check which.
Yeah, you need to see whether there's
and also,
HSCRP.
yes.
Yeah.
Yeah.
Yeah. Yeah.
Thank you both. I think, first of all, you've covered the medical and lifestyle. I was just wondering if both of you could talk about the mental well-being, mental health aspect of this whole journey.
Yeah.
It would be nice to get
You want
that.
to?
And how to solve it.
I guess the 6 pillars that she talked about, I think everything has a relationship to mental health. For example, building positive relationships, giving back to the community, and things like that. But what particular aspect would you want to?
When do you, is it good to, like in all this we're talking, is it also maybe very good to get professional help?
Always.
Absolutely, absolutely.
Of course. So when we talk about mental health, it really depends upon, is this affecting the quality of your life? So we can talk sometimes to our friends, to our sisters, to our mothers, but you can't necessarily, or to your partners, and you may not be able to expose everything that you want. And so it's money well spent if you find a good therapist who can actually help you rather than hurt you, because that's also possible. Just like you have good health professionals can be good and bad in every aspect. But also doing certain self-help things is important. We find, and I certainly find, that when people bring in lifestyle changes, they find that they are able to improve their mood. When you walk in amongst trees, that's why in the Japanese they say Shinrin Yoku, so walking in forest bathing. When you walk with a friend, when you laugh with the people, those are things that also help. When you hear about laughter clubs, you think, I don't want to be part of a laughter club. But even a forced laughter can actually help. So I would definitely do those things, but I myself have had therapy because I wanted to know how I can improve myself, and I found it really very, very helpful. So I do think that there is space for that. And also you might need antidepressants on top of HRT. You might need cognitive behavior therapy before antidepressants. There are so many aspects that we can't go in. That's why I go into those things in my book and when I have consultations, and on my website, because those are important things that every woman is unique in her experience of menopause. Every woman is unique in her perimenopause journey. So it's very important to find the bits that really are not working for somebody and then build on that. That's why I said you don't have to start with the nutrition. You might start with sleep, you might start with stress. But we do know that sleep and nutrition are probably the building blocks of all that, and they then have a domino effect. Did you want to add anything?
Yeah, I mean, it also depends on what is it and how long you've been feeling that way, right? So, I mean, there are some scoring systems that we use. When I see a lady sitting in front of me, I do ask some of these screening questions. Yeah. So it depends on whether it's sadness once in a while, depending on your circumstances and how you react to circumstances, or it could be a long-term issue, like over the past 2 weeks, if you've been feeling sad most of the time, tearful, emotional, not able to connect to people, just feeling on the edge all the time and worrying about small little things, then we're looking at probably, the onset of mild anxiety or clinical anxiety. And that would require, as Nitu said, initially CBT counseling, and then in certain situations, for example, in vasomotor symptoms, most of them are HRT works. But in mood disturbances in menopause, we do have to resort to anxiolytics and mild antidepressants as well. So it again is very individualistic.
Yeah. No, I know.
Yeah.
As you say, we have to look at women in the workforce.
Yes,
correct.
Absolutely.
So therefore, I'm just thinking, like, how do you get over?
It's a multi-pronged effect. It's a multi-pronged approach, I would always say, because this theory that you can manage completely without medications and this theory that you never need lifestyle and you only need medications is one of the main reasons why I've written both my books, is because I feel passionately that the woman is left in the middle helpless. She doesn't know what to do because she's taking all these medications, actually not feeling well, when all she needs to bring in is a few lifestyle changes. And on the other hand, she may be bringing in a lot of lifestyle changes, but she desperately needs surgery for adenomyosis or endometriosis or large fibroids or HRT for her menopausal symptoms.
It looks like you're probably a leader of some sort, or you kind of look after a cohort of women. And I think it's an important aspect.
Very important
so those
question.
of you
who
have women, say, under your subordinates, I think it's very important to make arrangements for some sort of a talk like this in your own setup. And the other thing that you could do as employers is, of course, give the opportunity to talk to doctors, as well as to give them opportunities to team building and things like that, taking them out and things like that. Also, when I go for the corporate talks, there are women in the higher sort of, rungs of the ladder who do not talk. I mean, there are people, CEOs and team leaders, who don't know whom to approach for any problems. Of course, they might have their own set of counselors, one person or two person, but they don't talk to the juniors or subordinates. They don't want to. So they feel very lonely as you grow up the ladder, right? So it's important for them also to seek help.
And it's important for all of us, each one of us who is in this room, to go out and actually spread more awareness. Because when you spread awareness, what happens is you bring in, suddenly you realize, oh, you've also had early menopause. I've also had. Oh, let's share this information. Oh, you've had cancer. I've also had. Let's share this. Suddenly you find people who you would never expect have gone through traumas that you look at them from outside and think, oh, she's got a fantastic life. Look at all her Instagram reels and things. And you realize that's not necessarily true. So bringing people together, like Aruna says, team building, all these things really make it such a difference. We are a very powerful, we're half the world's population. So, is it? Okay.
Yeah, go ahead.
I think they want mics.
My mother is 53. She had a menopause 3 years back. I want to understand how long do the postmenopausal symptoms last and what are the tests that are recommended?
Yeah, no tests that will look at hormones, but there's something called early postmenopause and late postmenopause. So in the first 6 years, it's called early postmenopause. So she may have symptoms like hot flashes, joint pains, fatigue, tiredness, mood changes, all the 34 symptoms that they may be there. Now, most of them will settle anywhere between 2 to 5 years for most women. But 1 in 10 women, even after 20 years, will still be having hot flashes. And things like joint pain and fatigue can last for a decade or more. So that's early postmenopause. And then you have the late postmenopause where you start having lipid changes, cardiovascular changes, brain changes, osteoporosis, all these. So it's really, when you're asking how long her symptoms, it'll depend upon what symptoms she's looking at. Is she looking at the acute symptoms? Is she looking at the later symptoms? And you're never out of all this, but it's just finding ways to address and deal with them as they occur, even before they occur. So, breast cancer and cancer risks are high as we get older. So you want to be bringing in those dietary changes, at your age, as soon as you hear about it, so that you're not that another statistics sitting in front of a doctor. So those are the little things. And you can't change genetics, but you can certainly change your lifestyle. Aruna?
You were also asking about tests to be done, right? So as I said in my slide,
Yeah.
those are all the tests to be done, which include bone health, heart
Thyroid.
health, all the bloods, the thyroid, even hemoglobin.
Yeah.
There's so many menopausal women
Exactly.
who have anemia, and anemia is less than 11.5 grams per
Yeah.
deciliter of hemoglobin. And it's really surprising that anemia is literally universal.
And vitamin D
the vitamin
deficiency.
D deficiency is universal. So we're looking at calcium, and just taking vitamin D supplements doesn't do the trick, because what does multivitamin do ultimately? It makes your bones absorb the intestine absorb the calcium. So it's important to have calcium as well.
Yeah.
And many of us don't have much calcium. There may be 1 filter coffee a day or maybe 2 filter coffees a day, and that's the milk that most of us have, I think. I'm not sure how much dairy you have as calcium supplements.
So I want to interfere there.
Yeah.
I would advise against calcium supplements because we know that postmenopausal women, studies are suggesting that there's an increased risk of myocardial infarctions and heart attacks. But what I want you to do is get calcium from your food.
Yeah,
One of the
they
main
don't,
reasons
so
why
that's the thing.
people are anemic especially in India, is because often you will combine your iron-rich foods with rotis and tea or coffee, and they all and dairy. Dairy will stop often the absorption of iron. So tea and coffee with the tannins will avoid the absorption of iron. So you want to be having things like brown rice or mushrooms or dals, but not at the same time as when you eat rotis. We know that when you're menopausal, you're not menstruating every month, right? You should be having good hemoglobin levels. And one of the reasons is the dietary combinations of certain foods. People don't realize they're often eating those foods that actually stop the absorption of iron and calcium and things like that. So I speak about that as well on my website. But certainly important to know, you need to get about 800 milligram of calcium, and the calcium comes from the soil. It comes from the plants. You don't need to eat dairy, or you don't need to take a supplement. You need to be eating things like till and sesame seeds and green leafy, lots of sag and all the
millets as well. So
and all these sort of foods that will actually give you, and of course, as you build your bone, vitamin D supplementation is important. And I would say for men, women, throughout the year, we don't get enough sunshine, even in a place like India, because we don't do work outside. We're in cars, we're through windows. So vitamin D supplementation, I would say check your vitamin D levels. You may need to take a higher dose, but I would suggest between 2,000 to 4,000 international units for all people, unless you know your levels, because you want to achieve 75 to 100. And all people after age of 50 should definitely be taking a B12 supplement, even if you're not vegan or plant-based. Really important, because our gut stops producing, the stomach doesn't produce enough intrinsic factor, so we don't absorb B12, even in omnivores, because B12 is put into animals, and they hope that it'll come to us, because B12 is produced by the microbe.
Yeah, and I think it's important to do a baseline vitamin D before starting taking supplements.
Absolutely.
Because you're already sufficient in that. You don't want to overdose yourself with vitamin D, right? Whereas B12 is metabolized very easily. So that doesn't make much difference.
And you
In
don't
terms
want to
of
be low in
calcium
B12.
supplements, I think, yes, myocardial infarction, that's because, of deposits, but most of the women, especially pregnancy and adolescents, need calcium from diet. If you don't get it, supplements,
In
we will have
pregnancy
to
and
resort to
childhood,
supplements.
yes, absolutely. We're talking about the heart problems in postmenopausal.
in postmenopausal.
And you just want to be a bit careful about that. Sorry.
Hi, Ben. My mother is diagnosed with osteoporosis, and I attended your session at Just Be also last year. So after then, I also follow a plant-based diet for like last 3 years. So my mother is also now, but she is still including the dairy because some doctors are suggesting us it has calcium. You should include that, but she is still not able to leave that. And second thing, I discussed with you last time about HRT, and you said that that should be done before 60, right? Yeah.
So over 60 is a very individualized decision, okay? You can take HRT, but you have to decide why you're doing it. If you're doing it just for osteoporosis, I don't think the science is out there because we don't know the effect of HRT over 60 when you're starting it for the first time. I would strongly recommend a strength resistance training, bringing in the soya diligently. Doesn't matter if she eats dairy or not, you know. What she needs to eat is in things like tofu sabji and soya, but also doing strength training. And strength training has to be with somebody who's able to manage somebody above the age of 60, not somebody who doesn't know how to help them build bone. Because it is possible, as you saw in my slide, women in their 80s, 90s, they can all do strength training. It's never too late. But HRT, yes, it is. I do put patients after 60 on HRT, but it has to be very, very specialized, individualized decision, and you might do it for a year, but then after that what? You know, is she having other symptoms? And so it's a complex area that has to be with the person. You have to talk to them and actually work that out. I don't know, Aruna, if you have any other suggestions here.
No, I agree. I mean, over 60, I would think twice, thrice before I start someone on HRT.
So now she's not 60, she's 57.
Okay.
But I was considering this decision, but then one more doctor said in our area that no, it is not advisable. If it is
what
not
are the
very
symptoms
urgent,
that she has?
only osteoporosis. So she has back pain and all.
Yeah,
this
at
stuff.
57, I would happily start HRT.
Okay. And I wanted to know, like, what are the, if someone is going for HRT, like you have been through, so what are the, pros that you feel like after doing HRT?
Just spend some time on my website. I literally discuss every single aspect. HRT is safe unless she herself has had breast cancer or clots in her legs. She can take it for the next 3-4 years, 5 years without any problems. As I said, I have 80-year-olds, 90-year-olds. The longer you take it, there's a slight increased risk in breast cancer. And in that situation, yes, it's a different. But I would still tell, my patients will still say, I hear you telling me I'm going to be at a slightly higher risk. I'm willing to take that because I want to make sure that I don't have these other problems. So you need to have a discussion. Rather, your mother needs to have a discussion. And it has to be a scientific, when your doctor says no, they have to provide you with the science. If the science is not backing up that person, you need to go see somebody else.
So would you almost always recommend HRT to
No.
sort of reduce the menopausal symptoms?
No, not at all. Everybody is individual. And so it is, some women just don't want to take HRT, and that's absolutely fine. They just don't like taking any medications. Others will do it, not want to take HRT because they can't take HRT because they're very scared. Their mother, their aunt, like this lady, has had breast cancer, even though it's not a contraindication. They may not want to take HRT because they themselves have had breast cancer or they've got a history of clotting problems. So there's a whole host of people who can't take HRT. But for those who can, the main reason, 1 in 10 women who could take, so for every 10 women who could take HRT in the UK, for example, only 1 takes it. And the 1 person who takes it, half of them will stop it within a few months. Why? Because they read or they hear somebody saying, oh, it'll cause you cancer, oh, it'll do this, oh, it'll do that. And
Lack of information.
That is lack of information.
What's your recommendation?
So for my recommendation is if somebody wants to take HRT and is happy to take HRT, I would strongly recommend it for anywhere between 2 to 5 years because of the protections that they get, because there are more and more evidence coming about brain health, we know about bone health, we know about heart health. So ideal time, if you're a British woman, I would say from 47 to 55, around that time. If you're Indian, I would say if you are somebody who's destined to stop it around 45, 46, I would do it from 45 to 50. And then if you're feeling so great on it and you want to carry on longer term after 60, then that is something that is a discussion that you would have and say, yes, I hear there is a slight increased risk with even these modern preparations. I don't want to take it. I want to come off it. But lifestyle has to go side by side because you are not taking, 99% of women are not taking HRT in their 90s, right? So, and you're going to live into your 90s. You want to live in like the blue zone people. How do you do that? So I don't like that word senescence, because I'm 62 and I do not feel senescence, the medical term of senescence. And, this thing about vaginal atrophy, which doctors we have coined. We are not atrophic. We just lack some estrogen. That's fine. We just have to find ways of building it back. And sometimes medical terms, I use those terms as well. They do us a big disservice because it reduces us down to symptoms when we are actually individuals and human beings with feelings and emotions. So yes, if you came to me and you said, I'm very keen to reduce my symptoms, or I'm having so many acute symptoms, of course you should have, But I would also be talking to you a lot about, the kind of foods you're eating. Why are you having so much of saturated fat in your dairy? Who's told you to have this tablespoon of ghee, which is full of oxidized cholesterol? Just because your great-grandmother had a little touch of it, she didn't get any of the other food that you were eating. Once you understand this, then you understand how to help yourself. Because when you help yourself, you help the climate and you help the animals.
Hi. Hi, hello, can you hear me?
Yeah.
Thank you so much for all the information. I actually had another question, but since we were talking about HRT, my question is HRT only to address symptoms? Because I've also had a hysterectomy. Is it really necessary post that to take HRT, even if I don't have the symptoms?
So again, as I said, you're doing HRT either for acute symptoms of hot flashes, joint pains, fatigue, and things like that, after addressing what Aruna said, vitamin D and B12 and thyroid and iron levels. If those have been taken care of and you're still having those symptoms, then you would consider taking HRT for a while. Or if you are worried about the longer term symptoms, osteoporosis and heart health, then if you're at the right age group, in your 40s, in your 50s, then that's the time to consider HRT. You shouldn't be afraid of it, is all I'm trying to say, because people are afraid of taking these medications that we know time and time has helped people, but you don't have to take it. At the end of the day, I was not given it, and then when I changed my diet, I improved hugely, but it was too late for me then to start taking hormone replacement because I'd gone more than 10 years not having had a period. So we want you to consider hormone replacement therapy either when you're in your perimenopause or in your early postmenopause, not in your late postmenopause, because that is not something that generally, unless you've got, as I said, osteoporosis, in those sort of situations, I might have that discussion because, the medications for osteoporosis are not very good at all. We do prescribe them, but they are known when you stop to cause rebound osteoporosis as well. So we want to bring in the strength training, the lifestyle, and the HRT before we bring in those medications. So I just want people to not be scared of it. Whether you take it or not is a personal decision, and nobody should be changing that decision, but it should be based on science and information. Aruna?
You had another question? No, I think again, this general sense that you want to know whether HRT is a universal blanket treatment.
It's not.
In my practice...
like I said, there's no particular symptoms as such, but going back, that leads to another question, which is what I had originally is, so recently I hurt my back, and then we had to do an MRI, and that's when, and we did a BMI, a bone density study test.
Yeah.
That's when, so borderline osteopenia has come up.
Yeah.
So now I've been put on daily cal. Every single day till I'm 60, I'm supposed to take. So again, that goes back to what you were saying about you wouldn't advise daily calcium supplements.
No.
But again, now there's osteopenia, and there's bulges in the vertebrae. So what is other than supplements, should I be relying only on plant-based foods?
Yes, plant-based foods, strength training is key. And you need to repeat your DEXA scan in a year's time, because when you do strength training properly and you bring in the foods correctly, you will find that you will build bone. Disc bulges are not a sign of osteoporosis. Don't get confused between disc bulges and degenerative changes in the spine versus osteoporosis and osteopenia. Osteopenia is the precursor of osteoporosis. I don't know if you attended Rajiv, my husband's lecture last year, but essentially what you want to understand is that if you are taking HRT to prevent osteoporosis, that is a valid reason, but it's not a commonly used reason. So it has to be done in a very systematic way, because people will start it, they will start having some breast tenderness, they will start having some bleeding, and they will stop it. So if you're not advised properly, you don't know why you're taking something. Okay, when women are having hot flashes and they take HRT, the hot flashes go, so they're very happy, they don't stop. But when you're doing it for other symptoms, you're not entirely sure why you're doing it. So I want you to educate yourself first so that you can get that information from an educated doctor, and also empower yourself from all the scientific resources. The British Menopause Society, the Indian Menopause Society probably also has lots of good information. So I want you to listen to that, but osteopenia on its own can be reversed by bringing in strength training and making sure that your vitamin D supplement, your calcium requirements are met through a good plant-based diet, strength training. These are very important, and you have to repeat the test. You have to repeat the test before somebody slaps you onto alendronic acid or something else. Then yes, in that case, I would say definitely try HRT for 3-4 years. Okay?
So most doctors actually don't recommend HRT, right? Today, even when we go and see a doctor and we ask them, hey, should we be doing this? And most doctors will say no. But what you guys are saying is that in the majority of cases, you would recommend HRT.
Yes.
And so we're all very confused.
That's exactly the sense I got when I listened to those, heard the questions. So when we talk about practice in India and the UK, right, because I've worked in both the places, right? So there is, what I do, having seen both the worlds, is I start with the history. So that's what I told in my talk as well. There's a history that we need to go through as to what your family history has been like. What are your risk factors for osteoporosis, for example? Or, you know, the other risk factors, right? So we put everything together. So that's why there's a pro forma sheet for it. We try to get all the information as to what your risk factors are. And initially, I mean, in the beginning, it's only the lifestyle changes, the vitamin D, the calcium, the thyroid and all that, and the weight bearing and the life, you know, all the other aspects of lifestyle and exercise. Then I go to sort of isoflavones for the first, you know, as a first step. But there are women who come with acute, severe vasomotor symptoms, and these are the ladies who require short-term therapy of HRT. I don't hesitate to give them HRT. There are women who think, okay, let me try the lifestyle changes for a few months, and then I'll come back to you. So these are the women who require follow-up. Right? Similarly, they might have other things going on in their body. For example, fibrocystic changes in the breast, right? Or a fibroadenoma, which is a lump in the breast. These require follow-ups as well. And if there is fibrocystic changes and they're on HRT, they need a little more vigilance, right? So these are all the things that we gather before we start someone on HRT. I don't stick HRT, I mean, everyone on HRT. So it is first this step, that step. Then if they're really not able to manage their vasomotor symptoms, the hot flash is really bad, affecting their quality of life. They go out to a party and they're sweating, you know, they don't know when the next sweating episode will happen. These are the women for HRT. For mood disturbances, we don't give HRT. HRT doesn't work for anxiety and depression. It works for the bone health, it works for the heart health, it works for the vasomotor symptoms, and it works for sexual function. But it doesn't work for mood changes. So we can't put someone on, you know, very bad mood changes on HRT. That's a different, that's completely a different ball game, right? So it's important to individualize. And of course, I don't know why you think Indian doctors don't give HRT. But again, there is a difference between Indian doctors who've trained here as compared to Indian doctors trained in the UK. I'm sure you are aware of that as well. There are differences in terms of how they counsel you and, you know, how they sort of do a holistic sort of thing. I'm not trying to be derogatory here, but the changes are there, and those you know, differences are there.
Yeah, I think doctors in the UK also, among the family doctors, they are very hesitant because of the sad you know, things that we have handed down over the last 2 decades of, you know, misinterpreting the studies. So the main reason why doctors are refusing or not advising is because they're still misinformed. They have got the relics of that previous information, and so they're not able to advise correctly. Now, as I said, nobody should be given a blanket, and I think Aruna is very correct. Everybody needs a proper checkup, but I would not use it as a second hand. I wouldn't, some women just don't want to do lifestyle. They just don't want to. In that case, I'm not going to deny them HRT. Others really want to try lifestyle, and then they'll come back to you if they want HRT. So it's so individualized that having a blanket for anything just smacks of a lazy doctor. A doctor who's not taking time to actually understand the person who's sitting in front of you and what their needs are. So actually understanding that and not fear-mongering, giving them the science so that they can go away and then decide for themselves how it would benefit them. And that is why you're educating yourself. That's why you're empowering yourself, so that you can empower them and see empowered health professionals and also question them. I have a whole chapter, both, I think even on my website, but definitely in both my books, on the questions you should ask your doctor. Because otherwise, if you're not sure, when was your last period, what 3 top answers you want, you will go in there, the doctor will ask you a few questions, they will do all the talking, you will come out completely confused and not sure at all at the end. So you have to go in with an agenda, because it's your body. Nobody loves your body better than you do, not your doctor for sure. So it's really important to understand that we are not saying HRT is for everybody, but boy, if you need it, you should get it. It is safe. But you have to empower yourself with the knowledge, otherwise you will stop it because you're having some breast pain, some bloating, and somebody's told you it'll cause weight gain, or you have bleeding and you stop it. And then you're missing out on a medication that could have helped you. But similarly with lifestyle, you get confused, you think dairy is good for you, you think animal foods are good for you, when actually you should be eating foods that are really whole plant foods. Study after study has shown it's not a different diet to look pretty, it's not a different diet to look younger, it's not a different diet for preventing dementia or reducing menopausal symptoms or reducing breast cancer. It's the same diet. It is eating mostly whole plant foods. It's moving your body, it's stressing less. Those are the things I want you to take away, not this, Mrs. Bajekal is recommending HRT for all of us.
I know there are quite a few questions in the audience, but we are unfortunately out of time. I'd like to thank Dr. Bajekal and Dr. Muralidhar for their time and their advice, and for being so open and honest with us. And thank you all of you for being open and honest with them. As they've mentioned, their books are available for sale outside.
I'll be signing some copies outside.
Yeah. And their talks will also be up on our website in a couple of days. So please share it with as many people as you think needed. Like Dr. Bajekal has reinforced over and over again, the more people that know about this, the more misinformation that we can prevent. Thank you all of you for being here on a Sunday morning. Please stay back and chat with the authors, and please do pick up a copy of the book. Thank you. See you all soon.